That rehearsal is really important for me because I get in trouble much less often. And I don't want to be mid-treatment and get in trouble. I don't want to have to change a plan where it was non-extraction and now it's extraction. Or it's a transposition that I was reaching too far and now I've created some periodontal problem. I want to know. Craftsmanship is important to the specialty, and I want to spend the next 20 minutes on it. Most of us in the room would consider ourselves craftsmen. And it's all about doing really good work, quality work that you pay attention to and you care about. I love mortarless stone walls. That is craftsmanship. It's how they learn to do that and how they figure out what doesn't fall down, and it's passed on through, more and more people that learn how to do this. And I just love when I see that because it just speaks art and science. There's control, but there's creativity, and that's what we do every day. So I'm going to challenge you with Elisa to put on your craftsman hat and imagine like a sculptor does with a block of marble. They can see the sculpture in it before they start cutting. I want you to look at Elisa that way for a minute. And whatever chisels and tools you have, I want you to think about how you're going to sculpt her case. So Elisa is 11. Severe class 2 deep bite. Lots of overjet. She's already broken her incisors off, both of them. Here's her overbite and overjet. Think about the tools you have in your toolbox and what you're going to use to sculpt her into that final result. Think about what the final result looks like. What do you expect to achieve? Some of you might be thinking, surgery. Gotta do surgery because she needs a chin, she needs mandible, all those other things. Some of you might be thinking distalizers. Some of you might be thinking functional. But just think about what the end result is, because that's how we all plan. Here's the three-dimensional information on her. And you're probably picking up a lot of clues, everything from mandibular morphology to incisal inclination. You're thinking about what your appliances do, what the iatrogenic effects of those appliances might be. Do I expect some incisor tipping? Can I get away with that? Does this appliance work better for this? Here's her airway. Not catastrophic, but it's not huge. And we'll talk about what's huge and what's small. What we decided to use for her was a functional. And actually use a twin block on Elisa, followed by full fixed appliances. She was in a twin block for 9 months and in full fixed appliances for 14. And this is the sculpture that I made. And I want you to compare that with the sculpture that you were envisioning and what you were going to create for her. And I'm very happy with her result because she had really good growth. I'm not taking responsibility for this case. This was Mother Nature's job. But I was able to guide it into a place that I feel good. And I'm happy with her profile. And I'm happy with her occlusion. And I'm happy with the interincisal angle. And if something works, I want to do it again. So she's not a difficult case to level and align, so this is not a tricky orthodontic alignment case. This is a big, big problem sagittally. So here's what she looks like post-treatment. This is what she looks like 2 years after. I'm still happy with it. And when I look at her occlusion, nighttime retainers only from day one, Hollies for Elisa. She had a fixed lower 3 to 3. Here's her occlusion 2 years later. Nighttime Hollies. I want to do that again and again and again and again. So when I see an Elisa and I can do it, I'm thinking, how do I repeat that? And if I get another case and I do the exact same thing I did on Elisa and I get a different response, I'm not going to throw out all these appliances. I'm going to think, why did I get a different response? What's the variable in this new patient that made her or him not respond like Elisa? But when we get things right, we should study them too. And more importantly, when we get things wrong, We should really study those. Here's what she looks like side by side. So again, put in your visual brain, I want you to superimpose your 3D sculpture of Lisa. What you expected her to look like following your treatment. Profile-wise, incisal angle-wise, occlusion-wise. And just consider whether you would be happy with this or you would like to see something better or different. Notice we've gotten some airway change. It's always helpful. Mandibular advancement does help, whether it's through functional or surgery. But looking at cases side by side gives us a perspective of what's different, but not a real appreciation of the change. And that's where it becomes very important to look harder. Bjork was an absolute pioneer. All of us in the room studied him, spent a lot of time with him. He taught us a lot about growth. Again, all his implant work was spectacular. I was fortunate enough to work under Dr. Shelley Baumrind, who had the Matthews collection, which is the only North American implant sample next to Bjork's in Europe. We did a lot of cephalometric superimposition, and all of us have learned a lot from Bjork. And a lot of Bjork's work and growth analysis comes down to the ethmoid bone, cranial base. Remember how we would superimpose on cranial base, and we still do. Cranial base is a three-dimensional object, and Birte Milson taught us that there are areas of quiescence and mild apposition, but most things are quiescent after 6 years old. Makes it a really good superimposition spot, which is why we've used it in cephalometrics for so long. Now, when you use these same principles on three-dimensional imaging and you start letting the computer take over by matching voxels on the cranial base, voxels on the ethmoid bone, you get really powerful superimpositions. Now, I studied from one of the best guys on reliability. And if you read Shelley Baumrind's papers on cephalometric superimposition reliability, you'll realize that there's error in every superimposition. We study this error like crazy in 3D, and what you're going to learn is that computers are really good at this. If you tell them where to go, where to superimpose, they'll match voxels all day, as long as there's quiescence. So I know if Bjork could see this now and knew we could superimpose in 3D, he'd say, I don't even need the implants, I got it all right here. Let's get to work. You'll notice all those principles we learned from Bjork and Milson, Sella dropping down and back a little bit, little remodeling at Nasion, Basion dropping down and back relative to ethmoid bone superimposition. All those things apply. And you'll notice that all the change down in the area we work, incisors, symphysis, maxilla, you'll notice how those changes start to pop out at you in the superimposition. This is what it looks like on the axial slice. That is 2 time points of the ethmoid bone superimposed on top of each other. And look at how well those things are lining up. It's just mind-boggling how well the computer does this. Here's what it looks like in the coronal slice. All those little tributaries of the ethmoid bone, they're all lining up and locking on. And we can now see all the change that's happening in the space that we work in the dental alveolus. So this is what we use it for. And this is what's called a 3-dimensional dynamic superimposition. What you're looking at, the orange is T2, the blue is T1. This is an anterior cranial base superimposition volumetric computer algorithm. What you're going to see is the T2 teeth and surface map of the jaw. Using these Bjork principles, we've just taken those teeth back to T1. So what you're seeing is now there's T1, there's the teeth in their T1 position, and they're going to move to T2. Now I'm only showing the T2 surface map of the jaw, so you're not seeing that morph, but notice how these teeth are moving. This is in 3 dimensions. And this really tells you what your mechanics can do. Now, because we only have 2 time points of data, all the movement in between is extrapolated. This isn't telling us if I moved a tooth over here and then back here and then got it to final, but it's telling me if I were to design a perfect treatment plan from A to B, this is what it should look like. So now it's almost painted my mechanics. How do I design an appliance to do exactly this again? And can I design an appliance that's more efficient than what I've been using? This is what it looks like in the maxilla. We talk about headgear effect of functional appliances. I don't see it on 3D superimpositions. Notice how the molar moved down and forward. 9 months of twin block. I think we're all going to be very surprised how rarely we distalize anything. It's mind-blowing to see your limitations when you start looking. And that's what's really important to me. And I think that's really important to our specialty, that we really get to the truth, open our eyes, and figure out what our mechanics are doing. Notice these changes in the transverse. We've never seen superimpositions like this. And to understand how those lower molars sweep in underneath the maxilla and we level that curve of Wilson, that's all new information to me. When I started looking at this, it really revealed what my mechanics were capable of and what they weren't. This was the best we could do with soft tissue for a long time. A couple cartoon drawings and a few angles. And we hung a lot of theories on that. Because of the way this data works, I can do a hard tissue volumetric superimposition and then look at just the soft tissue. So you're seeing T1 in blue, T2 in white, and just look at the subtle differences of the nose, the nasolabial angle, the lower lip, the chin, and in its volume, right? It's not just AP. You can start to appreciate the cheek change, the chin change. And that's really going to give us an understanding of what our mechanics as orthodontists do to soft tissue. An airway superimposition sounds ludicrous, but it's here. When these patients are positioned the same at both time points, you can do pretty accurate airway superimpositions and see what kind of anatomical change you're getting from T1 to T2. And we'll talk about what I think matters in just a minute.